Cheetah.
Hello, and welcome to Running from Cheetahs with Nikita. I'm your host, Nikita, and this is my charming co-host, Emily.
Thank you. Hi.
Welcome to this week's episode of the unofficial podcast of Child's University. And this week we have our very dearest Ismail Khaled.
Hello.
Say hello to the audience.
Yes. Hello, audience. Hello, my interviewers.
So some of you might know him as a teacher of gynecology and obstetrics. You're teaching 5th and 6th year students.
Correct.
Yeah, and you are also participating in some research in the university hospital. And we invited you because of your British charms and your interesting research, and because you're a great teacher, I think.
Oh, thank you very much, Nikita. This is very kind of you. I had to pay him a lot of money to say this, but it's okay.
Okay, so today we have a little tea party planned. I think the tea is coming in a minute now. But we can just jump right into the interview.
So we know that our guest was born in Egypt.
This is correct.
So we would just like to know how it was like to grow up there. Growing up, how was it like growing up in Egypt?
Growing up in Egypt, I guess, is probably similar to growing up anywhere else. You really don't know anything apart from where you're growing, so you don't start reflecting on what has happened except many years later. I had the
but
chance.
Now it is many years later.
Yeah, absolutely. Very, very many years later.
It's time for the memoirs.
Yes. So on reflection, actually, it was really great growing up in Egypt. My childhood was a happy one. I have 2 sisters, and both my parents are doctors. Both of them are psychiatrists. Whether you want to see this positively or negatively, I don't know. But as I mentioned, I had a happy childhood. From very early days, maybe because I didn't know anything apart from medicine as a profession, I always thought I wanted to be a doctor. I never intended to leave Egypt. I wanted always to go somewhere and study a little bit for a few months, maybe. But sometimes plans actually change. And they change very gradually without anybody noticing. So I left Egypt and moved to the UK with a plan to be there for 6 months, and I was there for 25 years.
It's a long time.
Very long time.
Have you then studied medicine also in Egypt?
Yes, I studied medicine in Egypt. I did my basic training in Egypt. In Egypt, the training in Obs and Gynae is called the residency program, something similar to what Americans would call it as well. And it's a 3-year program. I finished that and I got a post at the university in Egypt, and I did a year and a half as an assistant lecturer, and then as a lecturer, and then I moved to the UK.
So is medical school there for 5 years, 6 years? How long?
Medical school is 6 years, and you have to, after that, you have to complete a 1 year as a house officer before you become a registered doctor. So,
like internship?
Like an internship,
okay.
But you have to complete it first before you are formally recognized as a doctor.
And then you moved to UK because you what was your call to go to UK?
So when I was studying obstetrics and gynecology, I wanted to sit for the UK exam related to Obs and Gynae. It's called Membership of the Royal College of Obstetrics and Gynecology. It's 2 parts at that time. Now it's 3 parts. But it was 2 parts. You could, at that time, sit for part 1, which was like basic science in Egypt. It was an examination center at that time. So I did my part 1 as soon as I started my residency. But you had to travel to the UK to sit for part 2 because it had a clinical component. And of course, one of one of the important things is to try and do some clinical work before you sit for the exam, just to get used to the system. Because as you can imagine, systems vary from one country to the other, particularly if the language changes as well. Although we study medicine in English in Egypt, but when
you did.
Yeah, I mean, medicine is studied. Medicine, actually, all of the Middle East is in English, with very small exceptions, maybe Syria or something.
No, it's really new.
Yeah, but when we speak to patients, we speak to them in Arabic.
Yeah.
So my problem was, how can you say something in layman terms? Because you can speak the medical language to somebody who, in England, they might not necessarily understand the medical terminology. So,
yeah, it is actually a big problem also when I'm going back to Germany, for example, to do the practice. I feel very constricted in like just my medical terminology and my ways of expressing it. Yeah, but now it makes sense, because actually when I find a lot of Egyptian lectures on YouTube when I want to study for a particular subject.
Yes.
And they're all in English with just a little bit of Arabic intermingled.
Yes.
Yeah, that makes no sense now.
Yeah, well, because all the universities, all the medical universities in Egypt are English.
Yeah.
But just one question now. So you did your training in Egypt normally, and then you went.
Basic one. Yes, and then I went to England, where you do like at that time it was like a shortened version of it for a couple of years, and then you can sit for the exam. I must say I sat for the exam before I even completed the 2 years. I felt I was ready, and fortunately I passed my exams. But then actually I was really enjoying my training there. I just felt I was gaining a lot of new knowledge that I did not have before. Thank you very much.
This is very fancy.
Yes, you told us you're a big fan of tea.
Yes,
so we prepared tea for you. This is a black mixed with peppermint. Is it the way you drink tea in Egypt?
Yeah, I like that. I like the size of this cup.
Yeah. Is it more of a Japanese, I guess?
Well, I'd say I said the size, the shape. The type of cup is very different. It's not Japanese like this one. It's a see-through. It's like this, but much smaller. But the size is really. Thanks very much.
It's good. It's very good. I'm not used to tea, but it's fine. But I have to ask you something, sir. Just be honest. Were you a good student?
Me?
Nah.
I think I was fine.
Yeah. You told
I
us
attended every single lecture throughout the university.
You attended
every single lecture.
Well, I think you had
my colleagues were actually my colleagues and friends used to make fun of me sometimes.
Yeah.
Because I attended everything.
You go to every lecture?
I go to most lectures, I think, but
even lectures that were people thought were not good. Yeah. I still actually went knowing that they were not good, because I always thought actually you learn something even if it's not good. At least you learn that you should not be that bad when you grow up.
I feel embarrassed.
You learn from a negative example, basically. Yeah.
But at school,
So you were a good student.
Yes.
Yes.
I studied a lot.
You were dedicated.
Unfortunately, I don't know.
Fortunately, of course.
What? Yeah,
Patients are happy for that, you know.
No, it is good. I enjoyed the studies very much, and I enjoy Obs and Gynae up to now very much. It's a lovely branch. I think everybody should do Obs and Gynae.
So this is a call for everybody out there, and I want just to announce a little game that we're gonna do in the end. So we have a live audience, and everybody the game, let's do it like this. The game goes like this. Things I was always too embarrassed to ask my gynecologist and or girlfriend, and I'm too scared and or too lazy to Google, but now I can ask anonymously in a Twitch chat. Yeah. So this is the very long title of this game. It means that we have Obs and Gynae professional right here, and he might answer your very private Obs and Gynae questions.
Ask questions too?
We can ask questions too.
Okay.
Yes.
But this is this is not a game.
This is
This
not.
is because I have to give an honest answer.
Yes.
It is up to you.
Of course, and honest.
Yeah.
Yeah, I'm just checking.
Yeah.
Because a game is, by virtue, is a game. But this is not a game. You're making use of my time.
Okay, so if I have questions,
free medical advice for everybody.
Okay. And actually, for those of you who are planning or thinking of questions, think that this is a question that you never wanted to ask anybody because it's so private. And now you're going to ask on a platform where the whole world is going to see it.
You can also send pictures, no?
No.
Oh, no.
This was not part of the game.
So can I ask you this? You've been talking about gynecology. But why exactly should someone choose gynecology? Why? What's the reason? Why did you choose it?
Actually, this is a very important question because I mentioned briefly that both my parents actually are psychiatrists, and I think everybody anticipated that I'm just going to follow in their footsteps. There is a private clinic working very well. It would have been very easy for me to just step in and do that. But I'm not very patient. I am actually patient, but not extremely patient to be able to deal with very chronic problems. And psychiatry was actually for me one of these issues because it's a problem that will be there for a very long time. Obstetrics for me, actually, this is what got me hooked into obs and gynae, the obstetrics side of things, the childbirth. Is actually quite nice because you get an outcome in a few months' time, hopefully. And also the other thing is that you get in 99.9% a very good outcome. It's one of the very few situations in medicine where you go and tell the family just absolutely beautiful news. You have not removed an organ. You're not going to put somebody on medications. Somebody is pregnant and they deliver, which is beautiful.
It is the only specialty where you start with one patient and you end up with two in the end.
Yes, absolutely. But also, it's one of the specialties where you build a nice relationship with the couple who are coming to see you. You see them regularly for a period of time, and I'm told, I don't know, I'm not fortunate enough to be a woman and have babies, but I'm told actually that people always rate their gynecologist and remember them very highly because they were there when they had the baby. And of course, we have the biggest privilege, I think, in medicine and in life to be the people witnessing childbirth and actually being there, receiving a new person and holding this person before their parents can even hold this person. I think this is absolutely fascinating.
I think you're brave. I would faint.
You'll be absolutely fine.
I would faint, sir.
You'll faint maybe the first 2 times, but then you'll be absolutely fine.
It's not going to be nice for the mother. The doctor just fainted.
Yeah, well.
And was there one particular experience that have drawn you into obs and gynae, or were you thinking about this a lot? Were there maybe a teacher that has inspired you, or anything like that?
Well, actually, what did it for me, to be honest, is lots of things that we end up liking and hobbies that we do. Are related to positive feedback. So if you do something and somebody says, you're really doing it very well, then you like it even more. Although initially you might not have been sure about it. And when I was between 3rd and 4th year in medical school, I had the chance to do a few weeks as an elective attachment in the UK. At that time, and I did that in a department of obstetrics and gynecology by chance. And because at that time I knew nothing about obs and gynae, and I was fascinated by what was happening around me. I also had the chance to read a little bit during these few weeks from a small book that I got in obs and gynae. And when I returned back, and in 4th year in Egypt at that time, this was when we studied obs and gynae, I started the course actually knowing a fair amount and actually witnessing some of the clinical things that we are studying. So in a way, actually, for me, I just felt I stood out, and I just felt that this is the specialty for me. So I think this was really the main.
So really seeing it in real life. reading from the books.
Yes, and that's why I think early experiences are so important, and it's important really for all of us as teachers, and for you as future teachers, or maybe mentors of somebody who's younger than you, to try and make this experience as positive as possible.
I have a question. Do you remember your first delivery?
First delivery I did, or first delivery I witnessed?
You did.
I don't actually. It's just a shame. Why did you ask me this question? I feel very sad now. I feel really sad.
Okay, the first one.
I'll have some more tea. No, I think the thing is, you don't normally just do a full delivery on your own the first time. So people will just let you maybe help in delivering the baby's head, and then they take over, or something, or maybe cut an episiotomy, and then they do the delivery. I mean, there are different things, I guess, that happen. It's like your first cesarean section. You never really do a full one. I remember my first full cesarean section, because this was like a big deal. In Egypt, when you do your first cesarean section, you have to buy dinner for the whole of the labor ward. So it would cost a lot of money. I know, it's ridiculous.
What you have to
buy dinner for everybody.
Everybody in the hospital?
No, just on labor ward.
How many people are in the labor ward?
Well, lots of people. in Egypt, definitely. And the hospital I trained in, at that time, we had 12,000 deliveries a year.
But just dinner, no drinks, nothing.
No. Just tea. No, just food.
In your mind, people, you're calculating.
Yeah, you're
people not interested in.
Just don't eat this one; it's too expensive. Okay.
Yes.
Interesting. Yeah. Are you still very connected to Egypt? You would say.
Yes, very much so. Yeah. I go to Egypt roughly 4 to 5 times a year, and my university where I trained, they still actually invite me to speak in every annual conference that they have. They have a big conference every year. I'm very much linked with that.
Yeah. What is it? It feels that this is where your roots are. Do you feel there more home than in the UK?
When it's after a few years of living in the UK, somebody asked me whether I dream in English or Arabic. And I don't know actually whether I dream in English or Arabic. Do you dream in Czech?
Me?
Yeah. No. But I think there is no doubt that when you are at your original home, speaking your original language, this feels different to anywhere else. I mean, I lived in England 25 years. English is not bad, and all my friends now actually live in England, and obviously my children are in England. But still, actually, Egypt have something. And when you meet your friends from school or university, it just feels as if you only left them yesterday.
Yes.
So it's. I also think that your sense of humor is different when you're speaking your own language.
Yeah. Not only. I think it's many things. Sometimes you can connect maybe with people from your home country better because I don't know of just the way people are. I guess. Do you feel the same? Do you feel it's maybe? I can imagine there's a big gap between Egyptians and British people. Yeah. Except for the tea, maybe. I mean,
well, actually, yes. Well, the English tea is very different. It's tea with milk.
Wait, tea with milk?
Yeah, an English cup of tea will have milk.
You learned so many things during our interview.
An English cup of tea. I mean, normally people. Well, some people actually drink it black tea, but the majority of people are going to have milk. Anyway, we digressed, and I can't remember the question. I'm too old. I forget quickly.
If you feel more connected, or it's easier to connect. Or you like maybe let's say the type of people, the mentality of people. Do you more? No,
not necessarily the mentality. It's just I'll tell you something. I mean, whatever your home is. When I say home, I don't mean the country. I mean the building where you consider it as home. And this is where you feel most comfortable. You might go and stay in a 5-star hotel and it looks absolutely amazing and fascinating. But the minute you walk back home, you think, oh, I'm home. And you're happy about something. What is that something? I don't know. But it's the same feeling, actually, for me, when I go back to Egypt. You just feel, you know what's happening around you. You're fully intertwined with the environment or the culture or the weather or the food or the noise. I don't know, but you just feel home.
For me, the fact that I have people to feed me when I'm home, so...
Yes, absolutely. Nice. I can't agree more.
I think one last question before our first game. About Egypt. Do you have maybe some off-the-grid, secret tips for somebody who wants to travel to Egypt for the first time?
Yes.
Of course, there are the pyramids, and of course there's the sea. Is there something a bit special that you would recommend?
That people should do or shouldn't do?
Should do. And
both. Okay. Maybe your top 3 to do.
Oh my God, that's not one thing. So my top things to do in Egypt. I think, depending on what you want to do, Egypt has amazing beaches and of course all the monuments in whether in Cairo or along the Nile. You have to be on the Nile. You have to, in any shape or form. Don't swim necessarily, but go on a felucca, go on a boat, go on a night cruise, depending on how much money you want to spend. People say if you drink from the Nile, don't drink directly, but if you drink a small amount of tap water, people say that you'll always come back to Egypt. Whether it's true or not, I don't know. You can try this and let me know. And you have to go to the old part of Cairo, and because there is just it's just the atmosphere is really as if you've traveled back in time, and just sit there in a very authentic restaurant and just have nice food. So these are the things, in my opinion, that you should do. What you shouldn't do is. If anybody Egyptian is listening to me, they would hate me for this. But I was brought up this way. Don't eat salad outside the house. Otherwise, you will live the consequences. So make sure that you eat salad at home. Just fine, wash it, but no fresh salad. In my opinion, maybe it's a reflection of my age because obviously I was a young person in a different millennium, but I don't think Egypt is a country for backpacking. So don't just turn up in Egypt and find your way. You can do this if you're very brave. I don't know, but
that was my plan actually.
Okay. So for Nikita, obviously, because of the game, you should backpack in Egypt. You should eat salad, and you should swim in the Nile. This is my advice to you.
And drink water.
And then drink water while you're swimming.
Okay.
This is just for Nikita.
I think it's a nice compact list. Then we have a very special game prepared for you. I'm very excited about this one.
I think you don't understand the meaning of game.
No. This one is actually fun. I think
Okay.
it's also related to gynecology. So you know that ancient Egyptians they had already a very amazing culture, and they also made progress in medicine. They were probably one of the first ones to really have medical literature and standardized medical literature. So there is this this papyrus, or it's called the Medical Papyrus of Kahun. I don't know if you heard of this. Yes. It is.
This is how we study medicine in Egypt. This is our textbook. We just read this and then off we go. We just treat people.
I found basically a few case reports from or common conditions that they had to deal with in the ancient Egypt. And so the game is that we'll present you this condition, and then you will think as an ancient Egyptian doctor,
Right.
yeah, and you will propose a diagnosis, and then we have options for treatment. So you can choose an option for treatment. This is then the multiple choice, yeah, and then
Sorry, is it a multiple choice or single best answer?
it's a multiple choice.
So more than one answer is okay.
It's possible, yes.
It is?
You said multiple choice
That's not...
or single choice.
Okay, single choice then,
Okay.
according to the doctor.
And then maybe you can think of what could it be in our modern terms? What kind of problem could this be? What kind of diagnosis would you pose maybe as a modern doctor then?
Okay.
Yeah, let's try this out.
Now let's try one. And see what happens.
Okay, so number
So I'm
one.
supposed to look at this screen, yes?
Yes.
Yes.
So
Okay.
treatment of a woman whose eyes are aching till she cannot see. It's a pregnant woman.
Pregnant woman.
Yes, a pregnant woman. So what do you think can this be diagnosed as? A pregnant woman with painful eyes that she cannot see. As an Egyptian, like ancient Egyptian doctor. You have any idea what this could be?
Should I think like an ancient Egyptian as well?
Yes.
Okay, well, if I want to translate this to obstetrics, the first thing that comes to my mind is, I don't know what they would have thought, but in current days, is this what I'm supposed to do?
You can do both intermingled. Think what maybe you would think of now and think of what they could think of back then, maybe. Maybe if it's too difficult to think about what they could think back then, then just about the current perspective.
So the current perspective, I would have thought maybe this woman has severe preeclampsia and she has visual symptoms with blurring vision, and it's that blurred that she can't see. So she's an impendiclampsia.
Well, as an Egyptian doctor, as an ancient Egyptian doctor, you should actually be able to recognize that it's actually discharges of the womb in her eyes.
What?
Ooh.
It was, yes. So, but maybe you can do better with the treatment.
Discharges of the womb in her eyes. This is very interesting, because one of the things Hippocrates, not related to pregnancy, but and I know this is Greek side of things, not Egyptian, but he thought the premenstrual syndrome happens because of something related to the womb. He noticed the relationship between the menses and the premenstrual symptoms, and he thought that these symptoms are happening in the brain, and they don't. The woman does not get rid of them until they all come out through her womb, as in the form of a period. So obviously, all civilizations were very much interested in the womb.
Yes, and understandable. It's
Okay, so zero out of
0. So, but let's go to the treatment. So, what are the possibilities of treatment?
Based on
so let's put
the womb discharge coming out of her eyes.
Yes. So now she has womb discharges in her eyes. What can we do for her? This helpless woman with aching eyes. So we can fumigate her with incense and fresh oil. We can fumigate her vulva with incense and fresh oil, and fumigate her eyes with goose leg fat. Or we can give her fresh donkey liver to eat.
I think I would fumigate her with incense and fresh oil. Sounds the least invasive.
It is a correct answer, because actually all of those are correct answers. You should do all of those to treat her aching eyes.
But should be eating the fresh donkey liver while being fumigated, or are these different sessions?
I think in this particular order.
Well, actually, sometimes when you read these things, you get amazed as to how the civilization lasted for many years, thousands of years.
Or how we are out of touch with such delicacies.
Yeah, absolutely.
Okay, now let's go to number 2.
Okay. So.
Okay, now we have a woman who is aching when urinating, as if it's burning.
Okay. They still do this sometimes. So this still happens in the present day.
Oh, man.
So your possible diagnosis as a current
Doctor.
new era doctor.
Okay. And as
An ancient one.
as an ancient one. Okay, as a current doctor, I would have thought that this poor woman probably has a urinary tract infection.
It seems.
And I know this because I'm a very good doctor. I know nobody of you thought of that because you're just students.
Yes.
You know nothing. As an ancient Egyptian, maybe is something discharging out of something else? No?
Good guess.
Yeah.
Let's. It is just of the womb.
Okay. Well, the womb is a big issue.
Okay. What can we do for this poor woman?
I think I probably would fumigate something.
You just want to fumigate.
Yeah, I like that. We don't actually fumigate in modern medicine enough. I think we should actually just.
I am thankful
You just
for
get a spray and just spray the room. But
I
imagine you just walk into the room and just fumigate everything.
Hospitals would be so much more welcoming if we would fumigate
The Wolf or something?
the whole hospital.
No. I mean, not
It would be
interested.
so-
It's just the fumigation in general.
For the atmosphere.
Women must have been traumatized back then.
I didn't actually whether.
Is this for real?
It is actual. I researched and this is the. Okay, I trimmed it a little bit, but this is the true translation of the text.
Oh my. Okay.
Yeah. Okay, so let's
So let's
get
see.
to the possibilities.
Maybe cranberry juice.
It is incurable. We
No,
can't
why
do
not?
anything.
Beans of black mulberry and chufa, grinded and dilute in milk. And beans of white mulberry and chufa, grind it and dilute in fermented beer. I would go with the beer.
Yeah, I think probably
The beer.
everybody should have a beer. In this
Yeah.
situation.
And this is the correct answer. Very
Ah.
well.
See?
Yes.
Well done. Well
As
done.
you notice, I tried to imitate the multiple choice test that we get in the exam.
Yes.
And there is like just the detail is off.
Yeah.
Yeah, and then you have to figure out
Absolutely.
what is the difference between the two answers. Yeah. Okay, let's go to the next
So
one.
actually, this management is not bad because beer is diuretic. So it will clear the infection eventually. It was also sterile.
And
Beer was invented in Egypt.
See, alcohol helps sometimes.
do you have good beer in Egypt?
We have beer in Egypt.
But not okay.
But good and bad is a relative situation.
Yes.
I don't know. I mean,
It's a yeah.
some people say,
I'm
I
just-
hate this, I love this.
I'm just a big fan. So
Of
I
beer?
would- yes.
Well, I mean, you should go to Egypt. Definitely. Let me know if you go to Egypt.
I will.
I'll make sure. We are only 100 million, so we know them all. We know each other.
Yeah. Okay. So now, how to determine if a woman who shall conceive from the one who shall not? So basically, what could be a pregnancy test of sorts?
It's gonna be
I think I know. I don't
Yeah.
know the details.
So
Did
let's.
they have to urinate on seats?
Oh, you were just. you paid attention in the university.
You were a good student.
It was our main book. Have things moved on since then? This is what I use for my teaching at Charles University.
Yeah. So, but I worked on the possibility.
What?
So bring her to.
Can people see the screen as well?
Yes, they can.
Yeah.
So bring the woman to a female donkey, and if the donkey screams, the woman is pregnant. Then let her urinate on the back of barley and the back of emmer. If the seeds grow, it is pregnancy. Smell her urine. If it smells like roast, it is pregnancy.
I would go with B.
So yeah, it was your
Your guess. Actually, you said that.
yeah. It was. I actually read there was some studies done on that, and it's supposed to be quite accurate, like 70 to 80% even.
Yes.
So not
I
too bad.
I don't know,
for-
but I can imagine actually if you're going to wait for the seeds to grow, then probably by that time the woman is obviously pregnant. It's like, the woman coming back 3 months later to check on the tree. And, I think I'm pregnant.
No, actually, this reminds me of something back home because of the urine situation.
Because of the what, sorry?
The pee situation, the urine. Sometimes Asian people from Cape Verde, they believe that urine can cure when you're sick and if you have a fever. So I have a friend and he was feverish and all these things. So actually, his mom had to pee on him for it to stop. So I kind of understand it. I'm not a fan though.
Yeah.
So don't do this at home to your kids, please. It's traumatizing.
Yeah, but I guess so. Is your friend better now?
Yeah, he's alive. I guess it worked.
Good. And is he still talking to his mother? Or
Are you still talking to him? I think he is. I think he is.
Just checking.
Just checking,
Did it have to be like directly or could it be from a cup?
I think it was there. I didn't ask him, but I should ask him that.
Because people say actually, I don't know whether people or was it in Friends, if somebody gets stung by a jellyfish, somebody will have to pee on them.
Really?
It was in Friends.
They do say it. I'm not sure if this works. Yeah, but this is a common thing people say. Like it's supposed to help against the pain.
If someone peed on me, I would be so mad.
But if it would stop the pain,
I don't care. No.
That's an
okay. Okay, I think that this is the last one. So treatment of a woman aching in her legs. So there is also a test, for a woman with aching in her legs. So if we bandage her, if we give her bandages soaking in raisin of milk, and if it becomes sweet, after she has done all of that, it means health. And if it's not, so if after wrapping the legs in bandages, if the raisin becomes sweet, is how I interpret it, and this means health. But if it's not, then what can this be?
You mean somebody tasted the bandage after they wrapped?
Yes, I assume that's how it goes.
This would put a whole new situation to award round in the morning. Just have to go and taste bandages.
Yeah. So if now the bandages are not very sweet, and after being on the aching legs of the woman, what kind of diagnosis could this be? We have basically.
I know.
Yeah.
Womb discharging or discharging womb?
Yes, it is.
Everything circles back to the womb.
Okay, this is fine. They only had one problem in Egypt.
A very big one.
Not building the pyramids, not getting any. It was just the womb.
No, the pyramids was easy.
Yeah, absolutely.
That was easy.
Okay, what can we do for this poor woman? Let her drink fresh donkey milk every morning for 4 days. Pour over her rancid oil. Place a raisin of milk on her after doing this. Let her bathe during full moon, and don't forget to fumigate.
Everything goes back to fumigation.
Well, we like the fumigation. Anyway, so we will do it, irrespective of whether it works or not, because it's nice. But I think maybe drink fresh donkey milk every morning for 4 days. It sounds like a prescription. Oh my God!
It's the second one. Yeah.
No, this is.
I think the hint was that we're doing diagnostic tests with the raisin before, so using the raisin again made sense.
Okay.
Yeah, but I forgot to
But
ask
I
you.
just wasn't sure actually about the rancid oil. Pouring rancid oil over somebody is a bit extreme.
Oh, that's extreme? That's a thing that is extreme? Oh, man.
But I actually forgot to ask you, what do you think a pregnant woman comes with aching legs? As a modern doctor now, what would be on your differential?
Aching legs. The first thing you think about, what's the first thing you think about if somebody comes with pain in their legs when they're pregnant? First thing?
In both legs or one leg?
Oh, good question.
Yes.
I like that. So he's good.
Yes.
He's good. He doesn't look good, but he's good.
It's
So tell me, one leg.
my mom tells me the same.
Oh, poor thing.
So one leg.
One leg, we should exclude DVT.
Absolutely. So this is the first thing. Pregnancy increases the risk of venous thromboembolism. Well done. Who was your teacher? It must be amazing, or she must be amazing. I don't know. And if it's both legs,
both legs.
She just walked a lot or something.
Yeah, I think. I mean, edemas are generally quite common.
There'll be a lot of the discomfort. It could be sciatica. It could be symphysis pubis dysfunction, where the symphysis pubis joint becomes a little bit lax because of the pregnancy hormones, and when women walk, they will get a lot of pelvic pain radiating to the leg. But yes, pain in one leg is serious.
Nice.
So don't pour rancid oil or just
don't fumigate.
Don't fumigate.
Was this game up to your standards?
It is great, actually. It refreshed my memory about obstetrics and gynecology. So I'm so happy.
Okay, so far, are pyramids big in real life? This is so far the response. Questions from the audience.
Okay.
I think so. They're quite big.
I haven't been there.
You have to go to Egypt at least once in your lifetime, and when you go there, you have to see the pyramids. The pyramids are impressive, and they're most impressive the first time you see them. Unfortunately, it was spoiled for me because we used to go to the pyramids as part of the school trip. So you go there as a child and you don't really appreciate it. But I was lucky to see the pyramids again in my friend's eyes, who came and saw the pyramids for the first time. They are massive. I don't know whether I should spoil this for you or not. But when you're standing in front of the pyramids, make sure that you stand and look at the pyramids with the desert behind it. Don't turn around.
Why?
Because there'll be a Pizza Hut and McDonald's, and you don't want that.
Okay. Okay, got it.
Oh yeah, that will spoil the view for sure. Yes. Never seen pictures from this perspective.
Yeah, nobody actually, except McDonald's and Pizza Hut, would take the picture from that perspective, but everybody else wouldn't.
So this person was asking, how was the tea?
I think this is.
How was the tea?
Yes.
The tea was great, actually. I'm really enjoying it. So thank you very much.
Let's switch gears then now and move from Egypt to UK. I think I was thinking that maybe a lot of students here, especially the international students of the university, they are maybe thinking or used to think before Brexit happened that they might go to UK for their training. Yeah, yes. Like it's quite a popular destination.
Yes.
So how did you experienced now working already in several countries? Yeah. What is your opinion? How is the doctor's life in Great Britain?
Yes. Well, I mean, first of all, if you want an experience outside Europe, then UK is a good place to go to. It's not in Europe anymore. But on a more serious note, I think the UK has a great training system. It's very structured. It's very organized, and you can get a chance to do lots of things, especially if you're part of the system. And after completing your training, you also do some subspecialist training in one of the. I'm only talking about obstetrics and gynecology because this is what I know. But the same thing applies to surgery and ophthalmology and everything else. So you can subspecialize as well. So you can become a gynecologist or minimally invasive gynecologist, ambulatory gynecologist, whatever it is. There are lots of specialties. So it's very structured. It's very organized. It is busy, like most of the training systems in Obs and Gynae anywhere, to be honest, unless if you are doing your training in a very small hospital. But it will be busy. You'll get the chance to rotate as part of your training, which I think is good. So you get the experience of maybe working in a district general hospital, in a university hospital, and maybe also in a smaller unit.
Do you have a lot of choice about place where you rotating to, or is it?
You would have a choice in where to apply, but it is also sometimes quite competitive. So you don't necessarily will get what you want, but wherever you train, the training will be very comparable. However, there are also crucial differences in the UK compared to the rest of Europe.
Which are?
Well, one big difference, in my opinion, having now worked here and also having trained in Egypt, is the use of ultrasound scanning in obs and gynae. So I chair a European group. I have lots of colleagues and friends in different parts of Europe, and everywhere you go and walk into a clinical obs and gynae room, there is always a scan machine because everybody scans. But in the UK, it's not the situation. So if you're seeing a woman in a gynecology clinic and you want her to have a scan, you have to refer her to a radiology department. They will have a scan. They will come with you back with a scan. This might be in 4 weeks, 6 weeks, depending on how urgent or not urgent it is. So not everybody scans. Of course, if you're doing fetal medicine, then yes, you are scanning, but you're an expert in this field. But they're very particular about things, some of the things like this. Also, the system of primary care, as in the GP and the secondary care, which is the hospital, secondary, tertiary care within the hospital, is very clearly demarcated in the UK. So you can't, as a patient, just walk into a hospital with a condition. You have to go and see the GP, and the GP would refer you to the hospital, which can be the case in some other countries, but not necessarily. But it's I personally think it's a great place to train. I'm sure it's also great in Germany and here definitely in the Czech Republic. But if you want to have a different experience, it's a good place.
Somebody from the audience is asking, what about the salary workload ratio? So work-life balance, I guess. If the salary is okay for, I guess, the cost of living.
Yes, I guess somebody's asking from a training point of view. I think when you're a trainee, I'll tell you 2 interesting stories about this. I don't know the exact situation now, but when you are training, I think your salary is okay for what you're doing. Interestingly, when I was a trainee and then I became a consultant, my salary dropped. So I was earning more as a trainee compared to being a consultant at that time. But this was before the European Working Time Directive. So we were getting actually lots of money because the hospital had to pay penalties that were overworked. Now with the EWTD, of course, the number of hours that any doctor can work per week and per shift is very regulated. So it's not as exhausting as before. Of course, this is a dinosaur talking, so anybody who's older than you will tell you, our times, we used to be awake for 3 weeks, and you can't be awake for 3 weeks. Anyway, so the workload to the salary, I think, is good. The quality of life will depend on where you are. If you are in London, life will be expensive, depending on what you want. If you want to be in a big, noisy city, it's great. If you want to be by the seaside, if you want to be by the countryside, then obviously don't pick London as a rotation and just go somewhere else. And it would be great.
You were in London?
Yeah, no, I was in the Midlands. My training was in Birmingham, and then in the northern part of the Midlands, in a city called Stoke-on-Trent, and then I went back to Birmingham. But I rotated in different hospitals within these 2 big cities.
So basically, you're saying that So basically, you're saying that you were earning more money when you were training?
But at that time, we were. It was just an interesting situation because at that time the EWTD was kicking in, but hospitals that have not moved to the European Working Time Directive compliant rota had to overpay doctors. As a penalty for what we've been asked to do. So at one point, actually, we were earning more than normal. But when you move to the consultant salary, the basic consultant salary was actually lower than what I used to earn as a trainee.
And compared to, for example, Czech Republic, Germany, is there a big difference?
There is a big. I don't know how much trainees are paid in the Czech Republic, to be honest. But of course, just looking at the different salary scales of different things, I think the salary in the Czech Republic is lower than in the UK, undoubtedly. But and this is, I've been here for 2.5 years. I think the quality of life you get in the Czech Republic is better because your money goes a little bit further away, because also the expenses are less in the Czech Republic. You know, you could be renting a flat for a much lower price. The taxes are less here than in the UK. If you want to buy a car, or if you want to go on traveling within the country, it is certainly cheaper in the Czech Republic. Food is cheaper. Beer is definitely much cheaper if you're interested in this. So yes, I mean, you just have to take everything together. If you can live in the Czech Republic and work in the UK, then you will be doing very well. But this will be a long commute every morning.
Very long.
I have noticed kind of one thing about British doctors, or British education of doctors, that there's a lot of effort put into kind of patient-doctor communication. Maybe it's my outsider view, but they seem to be just more polite, and there's this very more gentle approach, where when the doctor explains way more about the procedure, what is going to happen to the patient, you know, asking for consent and so on. And no offense to Czech Republic, but I feel this is a bit more rough here. It is a little bit more rough here. Yeah. So and also I like you have been teaching gynecology here, and I was like in your lectures, and I saw that there is also the style of teaching is different. Yeah. So in a way that you work way more with cases, and it's more clinical than is done, for example, by many teachers in our university. Would you say this is kind of the standard that is prevalent in UK, or is somehow politeness and this more clinical approach to teaching?
Or is it more your style, the way you?
I mean, I don't know. Actually, it's difficult to answer this question because I didn't really listen to many other people teaching and what they're doing. There are some universities in the UK where the whole teaching is based on PBL, problem-based learning. So everything is taught in the form of cases, and actually in these universities, like for example Manchester University, which is based on the McMaster University curriculum, the Canadian university, is all PBL, and the curriculum is done in a very different way, where you don't go and study anatomy and physiology and so on and so forth. You just have a case, and within that case, you will learn about a little bit of the anatomy and the physiology and the surgery and the post-operative care and everything related to that case. And you're supposed, by doing this over a 6-year period, you'll end up actually understanding the curriculum. Some people think it's a good idea, others don't. I think it's nice always in notification to strike the balance. So, having a case, in my opinion, just brings to life what you're studying. Otherwise, it becomes dry. You really don't appreciate what you're doing. It doesn't really make much sense. That's why I use cases. I've always actually used cases. So there is, of course, an encouragement in education now that people would use cases, even in questions. So we moved on from just giving you a twig and saying, what's the right answer, because this doesn't really help you in practical life. But the other thing, talking about communication, there are two aspects to this. Medical legalities are a big problem in the UK and in many countries. And so giving information and making sure the information is clear enough to people so that they can provide what we call an informed consent is absolutely crucial. If the woman does not understand, and I'm saying woman because I'm a gynecologist, but if whoever is being treated, child, man, woman, they are being treated and they don't fully understand, potentially if things go wrong, then this means they have signed something they don't really fully understand what they're signing. So communication is crucial. But communication is crucial not only from a doctor-patient relationship, it's doctor-doctor relationship, and doctor-nurse, and doctor-midwife, and doctor-porter, and everybody else around you. If you are a scary person or you don't communicate, it eventually will harm you. I attended a talk in a quality improvement project, if I have time, just very quickly. And this was actually one of the most fascinating talks I've ever listened to in my life. We were attending this conference in Paris, and the speaker was a surgeon, but he was also an astronaut, and he is the dean of a medical university. He's Canadian, and he was talking about his training as a surgeon, and he was talking about his training as an astronaut. And he said, of course, he's a senior person, so his training was many years ago. Things have moved on in medicine since then. And he said that when he was doing his training in NASA, everything that has happened there was the exact opposite of what used to happen when he was training for surgery. So in surgery, if you're in theater and somebody speaks, people say, shh, keep quiet. But in NASA, they ask you to speak up if there is any problem, because you might be picking up something. And if you don't say it, then it could be a missed opportunity. Yes, you don't have to be annoying, but actually, if you see something happening, then you should get the chance to talk about it. You will only talk about it if people around you give you the comfort to be able to talk about it. So communication is not only doctor-patient; it's everywhere. And this is part of the training curriculum actually now in all the Royal Colleges in the UK, which is the non-technical skills. We all focus on technical skills. You want to be the fastest surgeon. You want to do this. You want to do that. You want to have clinical sense. But we didn't really focus on the non-technical skills. How you ask somebody for something. How do you give people feedback? This is all very important.
I think this is extremely important topic. I have, from my own experience, I have witnessed, and it was in a German hospital. I was shadowing a doctor, and he would come into a patient in his room, and he had the to-do list basically, and he would come and start talking to the patient, and be like, "So first of all, you have cancer, and then second, we need to do a biopsy, and third." And was just such a striking moment for me, that the man started crying. You saw tears in his eyes, and he just wanted to ask the doctor like what exactly is happening to him, but the doctor just kept on talking and working up his to-do plan.
No, I think you're absolutely right, and sometimes as doctors you sit and say, what do patients want? I think it's a silly question, because we are patients. If we're not now, we will be at one point in time. So what do we want? Do you want somebody to give you 5 minutes? Do you want somebody to be talking to you while looking at the notes? Do you want somebody to just give you a piece of information and go? Do you want somebody to talk jargon? Do you want somebody to talk over you? No, you don't want this in any context. Even when you go and sit in a restaurant, you don't want somebody to come and take the order when they're really looking fed up. You just don't like this. And it's just a normal human interaction. And the other thing as well which is absolutely important in medicine, is honesty. I mean, if you don't know, just say you don't know. Whether you're teaching somebody else a question, you don't know the answer, just say you don't know. Don't make it up. People who are studying medicine by default are probably intelligent people. And if we think of the Gaussian distribution, they were yes. That's why I said with exceptions. No, I'm joking. But actually,
you already said that I'm ugly.
No, Keita, I like you.
Okay, yes. We should leave on good terms.
Absolutely, we'll always be on good terms. But it is really important. Don't think that you're smart and you're going to get away with things. People will just read your bluff. So.
Actually, about this, my dearest friend and we were talking about this the other day on the tram, and it's actually, he was saying something that really got me thinking, that at some point, he was saying this, Emily, you should be careful, because at some point, if you're very good, you probably will end up being arrogant. And I see this a lot in some doctors. They're very arrogant. The better they are, the more arrogant they get. And it's something that I feel like all of us med students, we should be careful with, because just because we have this knowledge, just because we're good at this, even if you get all straight A's or whatever, we should be careful, because that's a human life there. So we act like we are the owners of the place. If you're the surgeon, you know everything, you know better. That's not it, because you have a whole team behind you supporting you, the nurses, everyone else, everyone who's there actually. So I think it's something that we should all be careful, because we are the generation that's going to change things in a few years. So we have to stand with the mindset in ourselves. We have to set the right mindset, and this is very important. What you're
Very well
about.
said, Emily. I mean, I think you've hit the nail on its head. You're absolutely right. I think humility is something important for doctors, and we see life being created. We see life being lost, and sometimes, or at many times, prematurely, and you stand there helpless, not really hoping to be able to do something, and you can't really do something. Patients come and sit and tell us very confidential information about themselves, personal information that they've never shared with anybody else. And they just walk into the room, and just by virtue of the fact that you're a doctor, they tell you this. And you really have to take this with a lot of humility. I mean, we are very privileged, and we should always recognize this.
That was very well said. Now, I'm not sure what time. 1 hour.
Still 1 hour left?
1 hour.
You're tired of us, sir?
No, I love it. I just thought I was hoping it'd be like 3 hours.
No, but it's time to fly, right?
Yes, it was. We planned so much more to do. Like we didn't even touch your research. Now I'm a bit in doubt. Should we just briefly touch a topic extra, or you think we have to wrap it up? Yeah. Okay. Yeah. Then let's.
Do we have questions from the audience?
From the audience, so far nothing. I beyond they were just worried about money and tea and yeah.
Well, all are very important things, because we have to be paid to be able to function well.
Yeah, and tea is lifeblood.
Yeah, absolutely. Tea, a cup of tea after a delivery is absolutely important.
Tea after delivery?
Anything really. I mean, if somebody gives you anything after delivery, you have to take a piece of toast, a cup of tea. I mean, you're not going to pick and choose.
Yeah. So we would like to touch maybe one of your things that you have worked on a bit more closely, maybe. So you told us that you're doing research now on traumatic perineal injuries that are associated with deliveries. But I also know you told us in class that you have you've been working in a PMS clinic for some time. So it's kind of the choice that what would you like to talk about, Emily? It's your call.
About PMS.
PMS, okay. So PMS it is. We have a little graphic. We can show it to our viewers. I think, those are the main signs and symptoms. We just want to share it with our audience as well, so they can...
especially the male.
Yeah. Yes, especially...
To understand what we go through. So
PMS, it's like a little bit of an enigma. Yeah. Premenstrual syndrome. It is apparently such a vague but such a common thing. And can you tell us something about it? Like what is it?
Right. So it is true actually. It was not part of the plan, but I ended up doing a PMS clinic for about 3 years when I was working in Stoke with one of the world experts in PMS at that time, Professor Sean O'Brien. And I, when I was asked to do the clinic, I was absolutely petrified, because I thought, I know nothing about PMS. What am I going to do? But actually, it ended up being a very fascinating experience. So, premenstrual syndrome is not that common, what is very common are premenstrual symptoms. So there's a difference there. So most of the women who are having their cycles will experience some form of symptom. So a lot of women will know, I'm about to come on. I know this, not only because it's the time or whatever, but they might feel a little bit bloated, they just might feel a little bit under the weather, or whatever the situation is. Their hair looks different, whatever. I mean, people are different, and I'm telling you true stories from the clinic. But premenstrual syndrome are symptoms that are severe enough that affect the woman's social interaction. And these are really sometimes quite serious things. So somebody really becomes so irritable that they can't cope with their children, they start hitting them or fighting with the neighbors or crashing the car, or something really quite big. And these symptoms can be either psychological symptoms in a way, like somebody feeling down or sad or tearful or very agitated. Or they can be physical, and a lot of them are physical: breast tenderness, bloatedness, something really quite significant. And then, of course, there is a very severe type of PMS called PMDD, premenstrual dysphoric disorder. And this is a very extreme type of psychological problems where people really are extremely depressed premenstrually. The important thing about PMS, and this is what I've noticed in the clinic, we were running a tertiary clinic where people were referred from all over the country to see Professor O'Brien, who I was working for at that time, and hence I was doing the clinic. And they have been diagnosed with PMS and treated for many years. But actually, out of every 10 women we saw in the clinic, and I know this is a true number because I was recruiting patients for my Ph.D., which was on genetics of PMS. And so we had to do some charts to check whether women had actually PMS or not. They had to complete charts over a 3-month period before we could make a diagnosis. And out of every 10 women we saw, only 3 had PMS. So the remaining 7 had something else, which was considered to be PMS, but they had something called, I'm going to complicate things now, they had something called PME, premenstrual exacerbation. So they had a problem that got aggravated premenstrually. And premenstrual exacerbation could be somebody who has a mental health issue that becomes worse premenstrually, and then after the period they go back to having just a baseline problem. It could be asthma, it could be their diabetes gets worse, their epilepsy gets worse, catamenial epilepsy. So these are all premenstrual exacerbation of an underlying problem. So in a nutshell, lots of women have premenstrual symptoms. This is normal. This does not need anything. If somebody feels I would rather not have this, they might take whatever treatment works for them, which at many times is just something very mild. But if somebody has symptoms that are recurrent and they affect their life significantly, they can't study, they can't sleep, they are fighting with all their friends, they don't have any friends anymore, then they need something done about it. It's about only 2 to 3% of women would have this. Premenstrual dysphoric disorder is something very serious, and people would have sought help straight away. And this can be severe enough that some women said they commit suicide, for example, premenstrually. So it's something that is really very serious, and the incidence of this is even lower than 2 to 3%. I think if I'm invited again in a different life, I'll tell you how you manage PMS, but this will take a long time.
Maybe a last sentence about that. Like, what would you say to people, like usually chauvinist men, that they say, oh, it's just women that they're playing out, there's the time of the month again, and so on.
I think probably it's better not to talk to this person at all. I mean, just ignore them because they don't know what they're talking about. I mean, it's very sad actually when people say this. It's even more sad than when women say that a man has man flu. But with PMS, I think it is, for the premenstrual syndrome, it is actually a recognized disorder. And certainly it's in the DSM-3, DSM-4, DSM-4 revised, DSM-5, so it's a recognized disease. And some women really struggle with it. Another true story, and it's fact. As doctors, as you will see in the future, if patients really like you, especially if you go to the UK, every now and then, every blue moon, they might send you a thank you card. And the first time ever in my life, and up to now it has not happened again, to have a thank you card from a husband was actually from the PMS clinic, which was very nice.
But just to say something, if your girlfriend or wife or friend is experiencing some symptoms like irritation and these things, just buy her something nice, you know. I'm helping my ladies here, so buy her something nice. Chocolate, flowers,
Maybe not
something
even buying,
else.
maybe just, I don't know, maybe a foot massage.
Perfect.
Chocolate is good because PMS is related to serotonin, and chocolate increases serotonin in the brain. That's why a lot of women have chocolate craving tremendously. Thank you.
Thank you very much. So thank you everybody for joining us today. Thank you our guests.
Thank you very
coming.
much, Nikita.
Yeah, I hope you
Thank
enjoyed
you so
this
much,
interview.
Amelia. I really enjoyed it, and I hope I did not disappoint you.
Not at
No, you
all.
did
It was
not.
very nice.
Yeah, so may everybody eat a little bit more chocolate and get more thank you cards.
And flowers.
And flowers. Yeah. So, and we're going to see you next time.
Thank you for joining us and have a nice weekend.
Have a nice weekend, everybody.
Bye.
Bye.